ventricle is actually crucial in the cardiac-induced weaning failure. Why? Because the weaning process is able to alter the three components of the left ventricular function. I mean, the left ventricular preload, the left ventricular contractility, and the left ventricular afterload. How and why does it happen? In fact, transferring a patient from mechanical to spontaneous breathing ventilation triggers three basic mechanisms, and these basic mechanisms will eventually alter the three components of the left ventricular function. The first and the most important of these basic mechanisms is a decrease in the intrathoracic pressure. It's obvious that transferring a patient from mechanical to spontaneous breathing ventilation decreases the intrathoracic pressure. But what we must keep in mind is that it must be much more important in some very special circumstances. First, in case of intrinsic PEEP, in case of bronchoconstriction, and in case of resistance of the tracheal tube. And so it's also obvious that this decrease in the intrathoracic pressure might be much more important in COPD patients. And actually, in this study, in this cornerstone study that Michael Pinsky already showed us just before, by Lemaire, Teboul, and co-workers, you see that in these COPD patients, these authors assessed the intrathoracic pressure by measuring the esophageal pressure. And they were able to show these very large negative swings in the intrathoracic pressure. Very importantly in this regard, we must keep in mind also that all the weaning trial modalities are not equivalent in this regard. And this has been shown by this very nice study published last year by the team of Jordi Mancibo. And these patients were submitted to three trial modalities. First, pressure support with PEEP, a pressure support without PEEP, and a TPIS trial. And you see that the most important negative swings in intrathoracic pressure were clearly observed in case of the TPIS trial, suggesting that this trial is the most challenging for the heart. The second basic mechanism is an increase in the work of breathing, as told us just before by Dr. Pinsky. And this increase in the work of breathing can be of huge magnitude. And for instance, in this study here, you see that transferring a patient from mechanical ventilation to a TPIS ventilation increased the energy expenditure for ventilation at least twofold. Finally, the third basic mechanism is a huge adrenergic stress, and this might be caused, of course, by the emotional stress, but also by hypercapnia that might occur during the weaning trial. And again, in this very important study, you see that transferring the patient from mechanical to spontaneous breathing ventilation increased the level of norepinephrine plasmatic level twofold. And so this is also a basic mechanism by which the spontaneous breathing alters the components of the left ventricular function. How does it work? First of all, the weaning trial increases the venous return and the left ventricular preload. And this is due to the decrease in intrathoracic pressure. Why? Because the decrease in the intrathoracic pressure is transmitted to the right atrium. And so there is a widening of the pressure gradient of the venous return. The venous return increases. If the right ventricle is preload dependent, this increase in stress is transmitted to the left side, and eventually the left ventricular preload increases, what might induce weaning-induced pulmonary edema. But, and this is a very important point, this increase in the left ventricular preload occurs in all patients during a spontaneous breathing trial. But the weaning-induced pulmonary edema does not occur in all patients. Why? Because the key point might be a decrease in the left ventricular compliance. What are we speaking about? We must go back to physiology, and in fact, you know this relationship between the LV diastolic pressure and the LV and diastolic volume. And the slope of the curve is related to the left ventricular compliance, what means that if the left ventricular compliance is impaired, then the same increase in the LV and diastolic volume induced by the weaning trial might induce a much higher increase in the LV and diastolic pressure in PAOP and eventually in the risk of pulmonary edema. So the consequences of weaning are much more deleterious in case of impaired ventricular compliance. And as showed just before by Dr. Pinsky, in this study, Lemaire and co-workers were able to measure both the PAOP and the LV and diastolic volume. And actually, they were able to observe these two different patterns of relationship between volume and pressure and to show that some patients clearly exhibited some impaired LV compliance. What might cause this decrease in the LV compliance in practice? First of all, a previous left ventricular disease, of course. Also, the myocardial ischemia that might be induced by the weaning trial, and also the right ventricular dilation. Of course, this right ventricular dilation might be very important, and I think that this is the purpose of the next talk, because if the right ventricle dilates, then it might compress the left ventricle, impedes the left ventricular feeding, and eventually decrease the left ventricular compliance. If the right ventricle comes to dilate, this is, of course, because of an increase in the pulmonary vascular resistance that might be caused by hypoxia, hypocapnia, or, as told before, by a stretching of the alveolar vessels in case of lung hyperinflation. So just to summarize, concerning the effects of weaning on preload, we've seen that while it's constant and it's due to an increase in the venous return, but it might have a much more deleterious effect in case of a decreased left ventricular compliance. What are the clinical correlates? In fact, since it's constant, it's justified to give nitrates and diuretics in patients with a weaning-induced pulmonary edema. And for instance, in this study again, you see that all patients, all these difficult-to-wean patients, received an intravenous furosemide injection. And so 9 of these patients were eventually weaned from mechanical ventilation with this treatment. The second clinical correlate might be that we should look for the right ventricular dilation in left ventricle in a difficult-to-wean patients, and of course this is the role of echocardiography. The second component of the left ventricular function that might be altered by the weaning trial is the left ventricular afterload. And again, this is due to the decrease in the intrathoracic pressure, which is really the most important basic mechanism we've seen before. Why? Because the intrathoracic pressure is the pressure that is surrounding the left ventricle. So if the intrathoracic pressure decreases, it's much more difficult for the left ventricle to eject the blood out of the thorax. Its afterload increases. Independently from any decrease in the intrathoracic pressure, the increase in LV afterload might be due to hypertension, which is caused by hypocapnia and also by the adrenergic stress. And in this regard, again, all the weaning modalities are not equivalent. And again, in this study by Mesquida and by Cabello and Mancebo, you see that the increase in the systolic blood pressure was much more important if the weaning trial was performed with a TPs. Again, this might be the most challenging trial for the heart. And as showed just before, this is very important because an increase in the left ventricular compliance might really tremendously alter the function of the left ventricle. And this was shown years ago now by Buda and Pinsky in this very important study. And during this Mueller maneuver, decreasing the intrathoracic pressure, you see that this resulted in an increase in diastolic and systolic volume, suggesting an increased ventricular afterload. As you know, it's very difficult to obviate the increase in left ventricular afterload in clinical practice. But in this interesting study, Richard and Teboul years ago showed that transferring a patient from mechanical to spontaneous ventilation decreased the left ventricular ejection fraction. But in this study, the contractility was not altered, as showed by left ventricular angiography. And the preload was not altered too. And so this suggested for the authors that this decrease in the left ventricular ejection fraction was due, during this weaning trial, to an increase in the LV afterload. But what's very important is that a normal ventricle is less sensitive to afterload than to preload, but a failing ventricle, as you know, is much more sensitive to changes in LV preload than afterload, suggesting that the consequences of weaning are much more deleterious in case of impaired LV function. So, to summarize concerning the effects on LV afterload, it's due to a decrease in the intrathoracic pressure and to hypertension, and it's less well tolerated in case of a failing LV. What are the clinical correlates again? First, it must be suspected if the systolic arterial pressure rises during the weaning trial. And so controlling hypertension might be crucial for fighting the weaning failure due to cardiac dysfunction. And so before the weaning trial, we should control hypertension in previously hypertensive patients, and during the weaning trial, we should fight hypertension with nitrates, which has the advantage to decrease both preload and afterload. Finally, the last LV function component that might be altered by the weaning trial is, of course, the LV contractility, and this might be due to myocardial ischemia. I strongly believe that, in fact, the main effect of myocardial ischemia is to decrease the LV compliance, as we have seen before, but it might also decrease the LV contractility. The occurrence of myocardial ischemia during the weaning trial is also provoked by hypoxemia and also by the changes in the loading conditions of the left ventricle. It's been evidenced by this study showed by Dr. Pinsky before. It's a very important study. In this study, patients had an acute myocardial infarction and they were ventilated because of a respiratory failure. And during the weaning trial, you see that myocardial ischemia appeared in a large proportion of these patients as assessed by a change in the ST segment elevation. Very importantly, and it's an important message likely, the occurrence of ischemia is not very frequent during the weaning trial. This is at least what suggests this review of literature published by Demoule and Lemaire some years ago. And you see that at the bottom line, the incidence is not very important. But even if it's not frequent, the occurrence of myocardial ischemia might be of critical importance. Why? Because it clearly renders the weaning process much more difficult. And for instance, in this study, in patients with myocardial ischemia, here assessed with a myocardial scintigraphy, you see that the duration of mechanical ventilation was much more important in case of myocardial ischemia. So, to summarize concerning contractility, we have seen that it's far to be constant, and it's mainly due to the occurrence of myocardial ischemia. What are the clinical correlates? First of all, and this is a very important practical message, we should carefully monitor ECG during the weaning trial and troponin in the hours later for detecting this myocardial ischemia in difficult-to-wean patients. Also, we should assess the LV contractility before the weaning trial because it's much more likely that a patient with a LV previous dysfunction experiences a weaning-induced pulmonary edema. And also, if ischemia is assessed during the weaning trial, we should consider angioplasty. This is at least what was suggested in this case report we've seen before. And in fact, in this patient, the authors had evidence of myocardial ischemia during the weaning trial, and at coronarography there was a critical stenosis of the left anterior coronary artery, and when this stenosis was dilated, you see that eventually the patient could be successfully weaned from mechanical ventilation. So the first key messages might be that the increase in the left ventricular preload is constant, and it justifies to administer diuretics and nitrates in difficult-to-wean patients. We have seen that the LV afterload, the increase in LV afterload is evidenced by hypertension, and it's less well tolerated in case of a previous LV dysfunction. And we've seen too that myocardial ischemia is not constant, but it must be systematically detected in difficult-to-wean patients. The last key message might have an important clinical meaning. What we might learn from this very complex and schematic pathophysiological representation is that there are two conditions that clearly predispose patients to a weaning failure from cardiac origin. The first one is COPD, because we have seen that clearly it might aggravate in large extent the decrease in the intrathoracic pressure. And the second predisposing condition is clearly a previous LV dysfunction, because again it aggravates the consequences of an increase in LV afterload and of course of a decrease in LV contractility. And so this is not surprising that the weaning-induced pulmonary edema is mainly observed in patients with a previous COPD and a previous LV dysfunction. And for instance, in this study again by Mancibo, you see that nearly 80% of patients who had a weaning-induced pulmonary edema during the TPIS trial had a prior cardiovascular disease, and more than half of this population also had COPD. And so the fourth key message might be that COPD and a previous LV failure are the two conditions that predispose to deleterious effects of weaning on the left ventricle. And I thank you very much for your attention.